And finally, Chapter 26, Soft Tissue Injuries, Part 3. When we look at burns, obviously once we've assessed it, once we know the extent, once we know the depth, degree of burn, we need to treat it. So first, your assessment of the burn needs to be very quick because you want to get to the point where you're finally treating the burn. And treating the burn starts with stopping the burning process. As long as the patient is still experiencing a large amount of heat in that area, more heat than the body can transform and convert, they will continue to be burned. It's the reason why when you accidentally burn yourself while cooking, you immediately put your finger under a stream of water. You need to prevent the burning process to prevent additional injury. We need to recognize, of course, that thermal burns are caused by heat. So if it's a burn that's been caused by an open flame, it's likely that it'll be deep. But maybe if it's a candle or something of that nature, it will be a specific area, a very focused area. If we're looking at a patient who's been removed from a house fire or a flash burn, obviously we're looking at bigger issues. Scalding burns that are produced by hot liquids are often seen in children or older adults. It can happen when cooking, but we also have seen scalding burns as abuse. So we need to be aware and look at burn patterns. And then of course, you ever touch something hot, you'll get a contact burn. That can happen often in children when they are unaware of an object being hot, when they've accidentally turned on an oven, those types of things. When we look at a steam burn, it's most often on the top of the skin. It's most often a scald. You may get somebody who opens the oven too quick, who opens the microwave too quick, and become very minor. Those steam burns can be very significant. And then a flash burn, often from an explosion, a very intense heat for a very short period of time. When we look at thermal burns, again, we need to stop the burning source, whether we're removing them from the area or they have been removed. Obviously, if there's a fire, that should be done by the fire department in appropriate PPE. We need to cool the burned area with sterile saline. But we need to be careful because too much cooling of the entire body can lead to hypothermia. We need to remove all jewelry or anything constricting, recognizing that swelling may occur and even that some of this jewelry may potentially melt to the skin. We need to make sure that after we have cooled the burn area and stopped the burning, we apply a dry dressing. So cool it and then dry, sterile dressings. Making sure we're assisting in maintaining body temperature, so covering the patient, preventing infection through that sterile dressing, and getting ALS to potentially provide burn management and pain management. Inhalation burns can occur in any enclosed space that has poor ventilation. You're looking at excessive heat when you're talking about upper airway burns, so superheated gases. Taking that first breath in during the explosion out of shock can cause burning in the nose, in the mouth, and in the trachea. And you're going to see in the lower airway damage when we're talking about particles and chemicals. So breathing in the ash, breathing in chemical byproducts, that type of thing. Each of these is going to create a problem with the airway that will cause many issues, including swelling. You've got to immediately consider the importance of your ALS provider, because as the airway swells, it's possible that a surgical airway will be needed, or that they will need to paralyze the patient with drugs to intubate them before the swelling gets too bad. So some of the signs and symptoms that you need to look for include a hoarse voice, so the vocal cords are damaged, singed nasal hair or burns around the nose and the mouth, and soot in the mouth or in sputum. So if they're coughing up soot, obviously we're seeing a high probability that they have inhaled superheated gases or particles. Consider the application of an ice pack to the throat to help with swelling, or a cool aerosolized therapy, humidified oxygen, which can help with some of the edema. And of course, that's based on your protocols. You also have to recognize that through the combustion process itself, you are creating gases. So as furniture, wood, etc. burn, there are toxic gases like cyanide that are being produced that may cause respiratory issues as well. Carbon monoxide is also an issue you're going to have because one of the byproducts of incomplete combustion is carbon monoxide. And so you need to consider carbon monoxide poisoning if a large number of patients are complaining of signs and symptoms. But that's also concerning because if you're in that same environment, you are being exposed. So you've got to be concerned with the potential for carbon monoxide in any fire. And that's not just of your patients, but of the firefighters, of anybody who is on scene, who is watching. It's why we need to have a good safe distance that we set up from our working fires. Patients with faintness, dizziness, headaches, lightheadedness, anxiety, seizures. So, these are all patients that likely are inhaling some type of toxic gas, whether it's carbon monoxide or another gas. So, you've got to make sure you are aware of everything that is happening. We need to decontaminate these patients if we're in belief that they are inhaling poisonous gases, because cyanide and other toxic gases can be absorbed in clothing. We need to, of course, put oxygen on them and support their airway as appropriate and provide them ALS support, because the ALS provider can administer certain drugs that can counteract the impacts of some of the toxic gases. But in reality, getting them to the hospital is going to be the best care we can provide. Chemical burns occur when a toxic substance contacts the body, both in liquid and powder form. These are often acids or alkalis that, as powders and liquids themselves can burn, but certain powders, when you add water, will actually react and cause a chemical burn. The eyes are, of course, very vulnerable to chemical burns. So we have to use caution with these patients, because if it's a powder or liquid that's still around, it's something that poses a hazard to us as well. As with thermal burns, the severity of the burn is going to be determined by the concentration, the duration of the exposure, and in some cases, the type of chemical that has caused the injury. So our standard nitrile or latex gloves are going to be a concern as well. They may not provide us the protection that we need. Management of chemical burns includes decontamination. So removing the chemical from the patient and ensuring that there's not continued exposure or re-exposure. We want to brush off powders and flush off after we have removed the powder. So brush, then flush powders, and get that clothing off the patient carefully without shaking off any more powder. If it's a liquid chemical, we want to flush immediately with copious amounts of water. We want to attempt to flood the area for 15 to 20 minutes. We want to consider the potential of runoff, so making sure we collect any of that water as we flush the patient with, and not to contaminate other areas of the body if we can prevent that. If it's eyes, we want to flush the eyes, holding open the eyelids so that the patient's not keeping their eyes closed and we get as much water as possible. Remember, just like our exposures and poisonings, when we're flushing the eye, we want to consider using IV drips so that we can direct it into the eye in a more focused way. Electrical burns are another issue, whether it's through general electricity or it's through lightning. High voltage burns occur when the patient makes direct contact with power lines. But we will also see low voltage electrical burns because ordinary household current can cause severe burns, cardiac arrest, dysrhythmias, significant issues. So you have to recognize how electricity works to understand how the burn can occur. There's got to be a complete circuit from source to ground, and electricity is always looking to flow to the ground. When there's an insulator, those are the substances that prevent a circuit from forming. So an insulator may exist, but once that insulator is gone, that electrical current is again looking for that conductor, allowing it to reach the ground. And that may be the person. That may be the individual when they touch that current and complete that circuit. How much, how long, the flow, all are going to play a role in determining the severity of the burns. And you have to be cautious because a person who has come in contact with live wires may still be in contact with live wires or the electrical source. So unless you have this training and the equipment, unfortunately, you may just have to watch while you wait for the power to be cut off, while you wait for the appropriate individuals to show up, because you should never attempt to remove a patient from an electrical source. No matter how many TV shows or movies you've seen where it's happened, it's not going to go well. So you do have to wait. And something to consider as you run car accidents and other technical type calls, always assume that a downed line is a charged and live line, so that you are putting your safety first. When you have a patient who has made contact with an electrical current and been burned, there will be a burn injury at both the exit and the entry points, with the exit point being the bigger burn. The problem we're going to find is that while we will see the soft tissue injuries externally, internally, we're not going to understand the damage that has been done. So there may be a lot of deep tissue trauma, but there's also the likelihood that your patient is suffering from electrical disturbances within the body that can cause cardiac dysrhythmia or arrest and respiratory problems as well. And if they're not in respiratory or cardiac arrest, you need to be prepared and expectant of that to happen. This is just a picture showing you that exit wound of a patient who has received an electrical burn. Management of electrical burns. Obviously, once they have been removed from the source, if they are in cardiac arrest, we need to begin CPR. We need to defibrillate as necessary, and we need to support the airway and the breathing as well. We need to treat all of soft tissue injuries that have occurred as a result with dry, sterile dressings, and we need to promptly transport this patient to the hospital. As we've seen an increase in taser use, we have seen an increase in taser use injuries. This is a patient who has been exposed to an electrical current through two small barbs or electrodes that have been inserted in the skin during deployment of the taser. You have to talk to your OMD or call medical control regarding removal of the barbs. Most Most of the issues that we'll see with the use of tasers are in patients who have underlying disorders. So it causes a dysrhythmia or sudden cardiac arrest. But you'll also have the potential that when this patient was tased, that soft tissue injuries occurred as a result of them falling to the ground. Because normally the taser is not deployed if they're sitting calmly. So you have to look for those soft tissue injuries that have occurred as a result. And while a low probability, we might see radiation burns as well. And acute radiation exposure is much more of a theoretical issue at this point, because we have seen, while we've seen an increase in use, we've also seen an increase in safety. We do have radioactive materials that are used in medicine. In fact, the treatment for certain cancers, like thyroid cancer, is radioactive treatment. But of course, our biggest concern and our biggest threat is the intentional release due to terrorist attacks. You need to figure out where the radiation exposure occurred, whether or not it's occurring in the environment your patient is currently in, and maintaining your safety is going to be a high priority, just like any other call. There are three types of ionizing radiation: the alpha, beta, and gamma rays. Alpha are easily stopped. They have little penetrating energy. Beta has a greater power but can be blocked by protective clothing that is specially designed. Gamma is the highest threat. It easily passes through the body and solid materials. So really, there's nothing that you can wear that will protect you from gamma rays. Most of our accidents that create radiation exposure, acute radiation exposure, are gamma radiation through X-rays. Distance, time, and shielding are going to be the best way to stay safe for this, allowing the hazmat team to decontaminate the patient appropriately before you start your treatment. But once you get them, it's ABCs: treat your burns, treat your trauma, and transporting them to the hospital. You also need to obviously let the hospital that you're transporting to know that that is what is happening, so that they can be prepared as well and put protective measures into place. The goal, of course, is limiting your time, increasing your distance, and shielding yourself from the source of the radiation. Time, distance, shielding. But from the patient's standpoint, treat the airway, breathing, circulation, and treat your soft tissue injuries that may occur. We've talked a lot in the last two chapters about dressings and bandaging. All wounds should be treated with the appropriate dressing and/or bandage. The top picture shows you dressings. The bottom picture shows you bandages. Your dressings and your bandages have three functions. They're going to control the bleed, they're going to protect the wound from further damage, and they're going to prevent contamination and infection. So control bleed, protect wound, prevent contamination and infection. Most wounds will be covered by a dressing because dressings are sterile. They come in all sorts of sizes. They start at 4x4, 4x8, go to 8x12, trauma dressings, universal dressings, etc. The goal is that for large wounds, you use large dressings. For small wounds, you use small dressings. But the dressing goes immediately over the wound. Gauze pads, great for smaller wounds. Small wound, small dressing. Big wound, big dressing. We do have adhesive type dressings for minor wounds, Band-Aids. So they have that sterile dressing, but they also have an adhesive method to secure it. You have occlusive dressings as well that prevent air and liquids from entering or exit the wound. Remember, occlusive dressings are going to go on your abdominal wounds and your neck wounds so that air does not flow through the dressing. Bandages, in the meantime, aren't sterile, and they are used to keep dressings in place. Bandages can include roller gauze, soft roll bandages, triangular bandages, tape itself. The self-adherent bandages are obviously easier to use, so they stick to each other. You don't have to tape it. It's just convenient. Adhesive tape can help secure both small and large. The goal, of course, is not using elastic bandages like ACE bandage as that dressing, because if you try to secure it too tight, it can become a tourniquet. So anytime you dress a wound, the goal is to ensure that there is circulation that is happening distally so that you haven't cut off blood flow. And then finally, splints can also be good bandages, securing and stabilizing broken extremities. But again, if it's an open wound, you're going to put a dressing over top of the injury and then apply the splint, not just put a splint on. If the dressing doesn't prevent the bleeding from continuing, then you're going to move on, of course, to your pressure dressings and your tourniquets as well.